Welcome, and thank you for joining us for the webinar, Virtual Crossmatches in Real Life, New CMS Guidelines, presented by the Transplant Diagnostics Community of Practice. Before we begin the main presentation, we have a few housekeeping notes to help you engage with today's discussion. There is currently a viewership polling question displayed on your screen. Please take a moment to answer this question while we finish the remaining announcements. This journal club is being recorded and the archive will be available next week on the COP Hub. Please note that your lines have all been muted so that only the presenters and panelists can be heard for the archive recording. If you have a question for our panelists during the webinar, we encourage you to participate by using the Q&A window in the Zoom webinar panel to submit your questions for consideration. Questions submitted via this chat section may be missed during the presentation. Please submit your questions throughout the presentation. Finally, at the conclusion of today's webinar, a short survey will appear on your screen. Please fill out this survey to help us keep our content current and engaging. I will now turn the session over to our moderator, Dr. Chiasso, to begin our presentation.
Thank you very much, Victoria. It is my honor to introduce our first speaker of the day, Dr. Luis Hidalgo. He's the medical director of the HLA laboratory lab at the University of Wisconsin-Madison. Dr. Hidalgo is a transplant immunologist who has worked in histocompatibility since 2008 and served as a board-certified director in Canada and the US since 2012. He maintains active research interest in transplant immunology, studying immune effector mechanisms of antibody-mediated rejections and other transplant diagnostics initiatives. Dr. Hidalgo is the past immediate president of the American Society of Histocompatibility and Immunogenetics, ACHI, and he has previously served on the Executive Committee for the Transplant Diagnostic Community of Practice, and he continues to be an active member of our COP. The list goes on and on. Luis, without further introduction, we are very excited to have you, and we are looking for your talk. Welcome, and please take it away.
Thank you very much, Yusuf, and thank you to our COP for the opportunity to help with this journal club today. Here's a list of our conflicts of interest for both myself and Dr. Goggins as well. And we will not be discussing any off-label use. Some of the things that I'm hoping to achieve by, on my part of the presentation at least, are to review the history of the damaging effects of donor-specific HLA antibodies in organ transplants, examine the concept of a crossmatch, and specifically how the single-antigen bead assay allowed for a virtual assessment of the crossmatch concept. I hope to assess the advantages and limitations of both physical and virtual crossmatches, and then finally understand the recent changes made to the CLIA guidelines by CMS regarding virtual crossmatches and the opportunities that this provides. Looking at the history of DSA, we really have to go back to the decade following the first kidney transplant, which was done by Dr. Joe Murray in '54. As we started transplanting non-identical siblings, a major problem was realized, particularly in a subset of patients, multiparous women, where the concept of hyperacute rejection was identified. This type of rejection is extremely damaging and can destroy a transplant within minutes if not controlled. Now, hyperacute rejection demonstrated to us the devastating effects of crossing high levels of DSA at the time of transplant. And this really gave birth to the field of histocompatibility because the entire field was founded on the need to prevent hyperacute rejection. And although we didn't really have many tools, up until one of the icons of histocompatibility, Dr. Paul Terasaki, developed the first version of a physical crossmatch back in the 60s. In his landmark publication in 1969, he showed us that when a physical cross-match was positive, the risk of an immediate failure, i.e. hyperacute rejection, was up 80%. However, in cases where that cross-match was negative, the risk dropped to just under 15%. Now, given that this was the only tool that we had in place, and it had such a dramatic impact on the outcome, this became the standard of practice instantly for any transplants going forward. So just to review briefly the concept of a cross-match, a physical cross-match, also known as a cell-based cross-match, tests for reactivity between a recipient serum against a donor cell. It's a fairly crude assay, and once you combine these two, you're going to determine whether the recipient has antibodies that react with those donor cells using a number of different outputs. In the case of a cross-match, we generally assume that any reactivity that we observe is usually due to HLA antibodies, although we know that this may not always be the case. Considering the evolution of cross-match technologies, we have the two main branches of cross-matches currently employed. On the left-hand side, we have cytotoxicity cross-matches, and on the right-hand side, we have flow cytometry cross-matches. No matter which cross-match you're starting with, the core two ingredients are always recipient serum against donor cells. In the cytotoxicity cross-match, we proceed with labeling the donor cells with a viability dye. The sera from the recipients you're looking to test are placed into the wells of these plates, which are aptly named the Terasaki plates. And then you add your labeled cells, you incubate, and then you add external complement to this to enhance its cytotoxic effects. And then you end up with a picture that looks something like this. You have some green cells, which are your live cells, and you have some red cells, which are the cells that have undergone lysis. And through this way, then the technologist that's looking at the results can estimate the degree of cell death on a scales between 0, 2, 4, 6, or 8, right? So quite a subjective assay, and something that requires regular ongoing performance by the laboratory to really be proficient. On the right-hand side, we have the flow cytometry cross-match, which is more of the norm, at least in North America, for assessing physical cross-matches. In this case, again, you're starting with the same two key ingredients, but now you're using a fluorescent staining of the IgG that is bound to the donor cells. The next step is you're going to provide additional fluorescent labels so you can identify T cells and B cells, and then you can assess the overall degree of IgG bound to both T cells and B cells. The major advantage of this is that you can predict the output depending on whether you're looking at a class 1 DSA, which should translate to a T and a B cell degree of reactivity, or a class 2 DSA, which should only translate into B cell reactivity. It is considerably more sensitive than the base cytotoxic cross-match. So that was what we knew with the very acute effects of pre-transplant DSA. And we realized that DSA can lead to immediate poor outcomes at the time of transplant, but we really didn't know a role for antibodies post-transplant, and this was debated for decades. And it wasn't until 1990 when Phil Halloran first reported what we now refer to as acute antibody-mediated rejection, or ABMR, which is mediated by antibodies arising from memory antibody responses. This was important because the discovery that cytotoxic cross-match negative cases can mount memory responses, it really flagged that we needed assays with higher sensitivity for measuring these HLA antibodies. If we look at this table here, we see that the two possible outcomes, most likely outcomes from crossing pre-existing DSA. In the hyperacute ABMR scenario, we are crossing extremely high levels of pre-existing DSA, and these are certainly easily detectable through crude, largely insensitive methods like the CDC crossmatch. However, in the acute ABMR scenario, this type of ABMR is generally associated with also pre-existing DSA, just present at much lower levels. And this is where we certainly saw that this would benefit from more sensitive methods. Luckily for the HLA community, in the early 2000s, a new type of solid phase assay was developed, and we were given the Luminex single antigen bead assay. The single antigen bead assay allows for the identification of up to 98 different HLA or class 2 proteins. There are 100 beads in the basic version of the Luminex, with the beads having different amounts of dyes embedded into them. So we have different ratios of infrared and red dyes, which will help the instrument identify the bead being assessed. The kits are available in either class 1 beads or HLA class 2 beads, each one providing up to 98 different specificities. The instrument itself is basically a flow cytometer, but a flow cytometer that focuses only on reading beads and not cells. The first laser helps to excite the combination of those two dyes I just told you about, and that tells the instrument which bead is being examined. The second laser will excite the phycoerythrin marker on the detection antibody, which then gives the instrument an idea as to how much antibodies are bound to that particular bead, right? So this is something that translates into the median fluorescent intensity, or the MFI value that we all talk about. Now, I did tell you this technology did open the door for doing the concept of a cross-match virtually. And the way you do that is that once you have the donor HLA type and you have the HLA antibody profile defined for a particular transplant candidate, you can simply cross-reference these two data sets to identify DSA, right? And this really forms the most basic concept of what a virtual cross-match is. Right, so the picture here on the bottom outlines how a normal cross-match goes, right? The two key ingredients, recipient serum, donor cells, except now with the virtual version, we're going to replace the recipient serum with single antigen bead results for a potential recipient. You're going to replace the need for donor cells with simply having the complete HLA donor typing, and this would ideally be provided at high resolution for reasons I'll discuss shortly. And then finally, instead of cytotoxicity or fluorescence measured on a flow cytometer, your output is going to be simply determining whether there is DSA based on this HLA antibody profile and this donor's typing. Now we have actual definitions of what a virtual crossmatch is. Back in 2014, the Clinical Laboratory Improvement Advisory Committee, or CLIAC, helped to define our current definition of the virtual crossmatch. And that definition says that it is an in silico analysis of a transplant candidate's existing HLA antibody profile in the context of a donor's HLA genotype. Now, we're still calling this a virtual crossmatch. So it's important to note that even despite what the name may suggest, the virtual crossmatch is not a conventional laboratory test, meaning that serum samples are not added to donor cells, right? There's nothing that's happening at the bench in a virtual crossmatch. Also note that at the same meeting in 2014, the CLIAC had also made recommendations for regulatory changes to allow virtual crossmatches to substitute for physical crossmatches. And again, we'll touch base on that in a bit. Now, there are many advantages of virtual crossmatches, and these include expedited organ allocation Again, because we don't need donor cells, there's no need to wait for physical cross-match results, right? So this allows for organ acceptance across longer distances, which translates into expanded equitable access. We have reduced cold ischemia time, right? So related to the above, this indirectly improves graft survival, also would allow for acceptance of recovered kidneys not currently being used because of extended cold ischemia time. We have increased sensitivity compared to cell-based cross-matches. So DSA detection by single antigen beads is far more sensitive than the most sensitive of physical cross-matches, which would be the flow cross-match, which gives us then higher confidence in the detection of pre-existing DSA. The preservation of laboratory resources is also an important advantage. And this is because physical cross-matches are time-consuming and often performed on call. In contrast, HLA antibody testing may be done during normal working hours, and the virtual cross-match itself may be performed not just from anywhere, but also at any time. So, a key requirement really in allowing single antigen bead data to substitute for physical cross-matches is to examine correlations between MFI values and cross-match output. Such correlations are demonstrated in many, many studies. I'm just highlighting a couple here just to show you easy, understandable graphics, where you can see, and the graph on the left here has single antigen bead signals on the y-axis versus flow cross-match across the x. And you can see that we definitely have a pretty decent correlation between those two, the two. And then a different study from a different center here on the right, where the single antigen bead data is across the x-axis and the B cell cross-match output is on the y. And once again, you see that there is a decent degree of correlation between the two platforms. Now, various other studies support the validity of virtual cross-matches. I'm going to highlight this particular study below, not because it's the only one, but this only because it was the key study that we used in facilitating the implementation of virtual cross-matches at the University of Wisconsin-Madison. Just to give you a little bit of background, UW has a history of being a true virtual cross-match only center. Meaning that we have not relied on the output of a cell-based cross-match at all for nearly 10 years. So in this study, 508 different samples were examined. All were defined as DSA negative by single antigen beads. The flow cross-match was performed, and the transplant proceeded, regardless of the output of the physical cross-match. And a couple of things that we note here, of the 508 DSA negative virtual cross-matches, 54 of these translated into a positive cross-match, which translates into approximately an 11% non-specific flow cross-match positivity. And this is on par with what's recorded in the literature, which states that it's anywhere between 10 and 15%. Non-specific positivity is what you should expect from your flow cross-matches. What's even more important, though, is that because this was looking at graft survival out to 8 years, right, because the transplants proceeded regardless, when you compare the positive versus negative physical cross-match cohorts here, there's obviously no difference out to 8 years, right? So this demonstrated to us that flow cross-match positivity in the absence of DSA is relatively common, right? It's 11%. That's not insignificant. But it is clinically irrelevant when the negative virtual cross-match is negative, right? And that's really the key, is this gave validity that it's the virtual cross-match that's really what's driving the clinical outcomes. Now, getting back to the topic of our journal club today, given the list of these obvious benefits to using the virtual cross-match, you may ask, why have so few centers moved to full donor acceptance solely by virtual cross-match? And this relates back to, regulations related to the CLIA histocompatibility component had not been updated since 1992. And luckily, we finally got an updated final rule released by CMS on December 28th of 2023, which went into effect on December 28th of 2024. And this updated final rule affirms the suitability of the virtual cross-match to be used as equivalent to a physical cross-match for the final pre-transplant assessment for compatibility between donor and recipient. So the lack of this specific language, I believe, is what held back many centers from implementing virtual cross-matches on a wider scale. But now that we have this text explicitly in this final rule, I think we can expect an increase in virtual cross-match implementation across various centers. Now, given the expected increase, I think it's also important to be aware of the limitations of the virtual cross-match. The limitations related to virtual cross-matches are primarily those related to single antigen beads, and they are worth reviewing. The table on the right here is adapted from a publication from Sullivan et al. Entitled ASHI and CAP Guidelines and Best Practice Recommendations for the Development and Implementation of Virtual Cross-Matching, which is currently submitted to AJT. And I just want to walk down that list. So one of the limitations, which is probably one of the more critical ones, is the presence of denatured, is that the single antigen bead manufacturing process may result in misfolded or denatured HLA molecules on the beads, meaning that neoepitopes, which are not normally accessible, would present. And these have to be recognized to avoid erroneous avoidance of potentially compatible donors. We've known about this problem for a long time. The graph here on the right comes from a publication back in 2008 by Morales, Buenrostro et al., where they examined an unsensitized male cohort and noted that these false positive reactivities are prevalent, but recognizable. Particularly at lower MFI values, right? If you consider like an MFI of between 1,000 and less than 5,000, we're looking at about a 60% incidence overall. What's even a bit more troublesome is that despite the knowledge of such artificial reactivities for over 16 years, this problem persists and has arguably gotten worse in recent years. Limitations of inhibitory factors or prosome-like effects. And technology works ideally. The single antigen bead technology works ideally well in low titer antibodies where there's no saturation of the beads and the detection is fairly straightforward. These things change once you get into a high titer antibody scenario because there's sufficient HLA bound onto these beads that when you have saturation, you're going to have complement activation because of the proximity of the FC portions of these antibodies that are bound to the beads. Once you have complement activation, you're going to have deposition of complement breakdown products, which can physically block the detection antibodies from binding onto the antibodies bound onto those beads. Right, so this means that we're going to translate into false negative or low MFI values. Luckily, we have various ways in the lab to easily deal with such problems. We can also have false low antibody levels in the settings of shared epitopes, meaning that some HLA antibodies are going to target epitopes that are spread over multiple beads. Meaning that this is going to be a dilution of the overall antibody strength and a reduced MFI values on any single antigen bead. Below is one example where these are all reactivities pertaining to one specific epitope defined on DP antigens and one set of DR antigens. Obviously, you can start seeing the problem as to the overall dilution of this signal. There's also a limited single antigen bead panel. So currently available single antigen bead panels are limited to, as I said previously, 98 class 1 on the known number of HLA proteins included out there. And so the graph here depicts the number of current HLA proteins known based on the IMGT database, which puts us at about 15,000 class 1s and maybe about 8,000 class 2s. And this is really primarily a problem for allele-specific antibodies, which may be missed in donors with fairly uncommon HLA types. Important to note that current standards for deceased donor HLA typing is for low resolution, but this data suggests that this is certainly not ideal for the identification of these allele-specific antibodies. We need to move to high resolution. Finally, we have intra and inter-laboratory variability, as well as variability in MFI interpretation. So these are issues related to lot-to-lot variability, tech-to-tech, inter-instrument variability, as well as the different modifications to the basic standard staining protocols that we all use. Most labs also usually have an MFI floor from which they begin to interpret MFI values, but there's no widely accepted cutoff for that floor. So different cutoff may also be applied to different HLA loci. So obviously there's a lot of noise here in the system, but in all fairness, the issues related or stated here are not specific to HLA. This is related to variability that would apply to any assay, any serologic assay where the output is based on a threshold or has any quantitative aspect. And the relevance of these problems should be dampened even once we accept the fact that single antigen bead assay is not really a true quantitative assay. It is only a semi-quantitative assay. So we should not be interpreting this the way we would interpret a sodium or a potassium level. Now, physical cross matches, I don't want you to think that there are no advantages to this. There are advantages. It really provides the only correctly folded HLA expressed, right? And this is because there are intracellular quality assurance programs built into every cell, which means that the lymphocytes used in the physical cross matches are only going to express correctly folded HLA on their cell surface. Right, so this means that we will be lacking the reactivity to cryptic epitopes that I just described for single antigen beads. There's also no need to extrapolate with rare HLA types, since you're always going to have the actual donor cells. The reactivity observed in physical cross generally reflects reactivity against even the rarest of HLA type donors. So I've just told you a whole bunch of information. So really, what is the ideal? Given the advantages and limitations of both physical and virtual cross matches, the ideal is simply to not rely on any single platform for the accurate identification of DSA. And even centers like ours at UW, where virtual cross match has had a long history as the sole determinant of pre-transplant immunologic risk, we do still use a variety of tools, including additional Luminex HLA antibody assays beyond the single antigen beads, and we do many surrogate physical cross matches to validate suspect single antigen bead reactivities. Then we get to the question of who can perform virtual cross matches, and this is really an important question, and the answer will depending on the nature of the virtual cross match. You can have really two levels of virtual cross matches. There's the basic DSA review, which is really a cross-reference of a recipient's HLA antibody profile versus donor typings. And I think we could argue that this can easily be performed by a trained non-doctoral lab staff member. However, the more complicated virtual cross matches are those that require additional clinical guidance. where the lab directors need to get involved because you have to review patient clinical history, medical status, and medical judgment may be required before we provide this consultation. And I'll emphasize that this is a consultation, not a cross-match. Now, regardless of who performs either form of the cross-match, we do encounter the problem of reimbursement. Currently, CPT codes for consultation, for the consultation portion of virtual cross-matches can only be billed by individuals with one type of medical degree, but not by PhD degrees. This is really unfortunate, and it's unfair and an arbitrary barrier to the majority of histocompatibility lab directors out there who happen to be PhDs. I do want to give a big shout out to the list of lab directors listed here. I had the pleasure of working with this team in putting together this virtual cross-match white paper that lists the guidelines and best practice recommendations for implementation of virtual cross-matches. I specifically want to give special thanks to Dr. Bob Bray, who has long championed the acceptance of virtual cross-match as an equivalent to the cell-based cross-match, and Dr. Cliff Sullivan for taking a leadership role in getting this the group of us together and helping us get this publication put together. As I mentioned previously, please look towards this publication coming out in AJT, hopefully very soon. And thank you very much.
So thank you very much, Luis. It's my honor to introduce Dr. Williams Goggins, who is professor of surgery from Indiana University in Indianapolis. He has performed more than 3,000 kidney transplant. He's surgical director of kidney transplantation at the hospital and as well as Indiana Hospital for Children. And he's also a co-director of the Transplant Immunology Lab. Dr. Goggins upon medical degree from Louis University School of Medicine, get training from Medical College of Virginia and VCU, and then at Mass General and Harvard Medical School. Dr. Goggins is a member of ASTS and served as OP team Histocompatibility committee before, and he's fellow of American College of Surgeons, as well as fellows of American College of Histocompatibility and Immunology. So Dr. Goggins has very combo of surgical and HV expertise. Please welcome Bill to share his experiments from Indiana. Thank you.
Thanks, Q. I'm going to be talking about the clinical perspectives in using the virtual cross-match. Basically, I'm going to be talking about looking at organ acceptance using the virtual cross-match. And also, if you're going to use a virtual cross-match to go to the OR, what are some of the logistics that you have to overcome that the virtual cross-match helps you to achieve. Additionally, I'll touch a little bit, like Lewis did, on the pitfalls and or the benefits of the physical cross-match. And I'll also consider, are we at a point where we could potentially retire the physical cross-match? So the first thing that one has to come to grips with is, what is your risk tolerance as a program for DSA? If you're a risk-averse program, then you probably don't want to be looking at any antibodies above a level of 1,000. I also have to say that just because you list unacceptables, having a match run, that is not a virtual cross-match. That's not considered a virtual cross-match. Just so I use the term unacceptable antigens, I'm not implying that it's what you put into the UNet as a virtual cross-match. If you're a program that is comfortable transplanting with known DSA, then there's DSA and there's DSA, right? There's class 1 DSA versus class 2. The class 1, low levels of class 1 will tend to go away in about a month, whereas class 2 is persistent. If you're looking at specific loci, the C loci and the DP loci, they're not as well expressed on the tissue. And so if you have the same tolerance for MFIs, you're going to be probably losing some ability to transplant patients with some level of C or DP. And then you also have to consider, are you dealing with a patient that you're going to be listing with a low CPRA? If you have somebody that has a low CPRA, say 20 to 30%, it doesn't make a lot of sense to transplant against a DSA when you can get a clean transplant and not have to worry about going against antibody. And there are some patients with very high CPRA, 100% CPRA, that if you don't transplant against some level of antibody, that patient's never going to have an opportunity to be transplanted. And so when you're dealing with donor allocation, patient recipient, you're always asked for, at least I'm always called for, quote unquote, a quick virtual cross-match. And these are usually, when you're looking at a 100% CPRA patients, the OPA will call you and say, hey, do you mind doing a virtual to see whether or not you're going to end up needing blood, or if you're able to do the transplant. Other high CPRA patients, in addition, you'll always get a call about zero antigen mismatches. Initially, you think, oh, if it's a zero antigen mismatch, then the chances of the patient having DSA is quite low. Well, there are certain patients that will have high levels of DP antibody, for example, and still have a negative virtual cross-match. Excuse me, have a zero antigen mismatch. You'll also get asked about pediatric recipients. And then the question always comes up, do you need blood for a physical cross-match? And if you're relying on a physical cross-match, you have to get the blood to you in order to perform the cross-match. What people don't realize is sometimes you can get the blood after the organs have arrived at your institution, and that has actually happened to me personally. So when you're matching your donor with the recipient, you have to take into account, for example, the recipient's age. Are you dealing with an older recipient that may be a little bit more frail and is not going to be able to tolerate any type of modulation with plasmapheresis? So you don't want to pass a lot of antibody with them. You're going to want to have a negative virtual cross-match. For younger recipients, it all depends if they have a lot of antibody or not. They certainly can withstand preconditioning and treatment. And then you have to look at the actual organ itself. Is the organ from an older older donor that may have hypertension and some element of diabetes and doesn't have as great, fantastic function as younger donors? Can it tolerate if you have a rebound antibody and develop AMR? You also have to look at the strength of the DSA. Certainly, if you have low levels, is it likely to rebound, or is it going to be responsive to treatment? And a lot of that has to do with your experience in dealing with either class 1 or class 2. Like I said, class 1 low levels after about 3 weeks tend to go away, whereas class 2 are certainly persistent, and you can certainly have an amnestic response or a rapidly developing antibodies that can hurt the kidney. When you're talking about using the virtual cross-match to go to the OR, this is where sort of the logistics are really helpful with using the virtual cross-match. You're going to use the virtual cross-match to decrease the cold ischemic time and to get the patients transplanted faster. Many programs, if you're a high volume program, you're going to need a little bit more flexibility with transplanting, particularly in our situation now, we have a very difficult time with OR availability. And so if you're very limited and you have the flexibility of going earlier with a kidney, if you're able to get a negative virtual cross-match, that's super helpful. We have OR team availability issues. And in addition, we also have anesthesia availability issues. So there are a lot of in the OR issues that you have to overcome sometimes, and having the ability to use the virtual cross-match as a negative and go to the OR cross-match for a final cross-match, it certainly is quite helpful. And when you're dealing with the no longer having just local donors, prior to the new allocation system, we had about 80% of our donors were from in-state, and it's a lot easier to predict when you're going to get the kidneys and to set up the OR. Now we get about 80% of our kidneys from out of state, and so it's much more difficult when you're dealing with transportation issues, if the kidney's being driven or if it's getting flown and stuff like that. So having the ability to be a little bit more flexible with your timing with the virtual cross-match, using as the final cross-match, is quite helpful. Addition, if you're dealing with DCD kidneys as opposed to brain death donors, and if the kidney is on the pump versus coming on ice, certainly the pump is able to extend the preservation of the organ. Ice storage, you really want to get the kidney in a lot faster. And waiting, if the kidney gets to you in 18 hours on ice, and you have to wait a couple hours for the cross match, that's certainly going to cause a higher rate of delayed graft function. We're already dealing with a high rate of delayed graft function now with all the DCD donors and the traveling of the kidneys. And certainly, if you're using AKI kidneys, you're going to want to get those in faster as well. And the virtual cross-match is exceptional at speeding that up. One of the things I want to talk about, like Lewis hit on, I think this is a really important point, particularly when you're dealing with things clinically, that the physical cross-match is a test, and tests can be affected by things outside of what you're testing them for. So if you have a virtual cross-match that is negative with low or no detectable DSA, the positive cross-match is due to non-immunological factors which are causing it to be positive. And some of these factors can be autoantibodies, a patient with lupus or HIV positive patients, to other non-HLA antibodies, or issues that will affect the beads themselves. And then certainly if you have immunomodulators, one of the more common ones are the anti-CD20 monoclonal antibodies, but other issues with all the treatments for rheumatoid arthritis and with lupus, they're using all the new agents that can affect the cross-match. And there are some risk-averse programs that might mistakenly not transplant a patient with a positive physical cross-match and low or no detectable DSA. This is just one of the patients that had a very high positive cross-match with very low, we would not even really report DSA less than 1,000, but in this particular case, because the cross-match was so positive, with an MFI of 600, this cross-match is due to non-HLA issues, and we of course went ahead with the cross-match. This was just one from last week that had a patient that came in that had 0% CPRA, had a positive B-cell cross-match, and it was due to autoantibodies. And so that's just another example of what's going to be causing the physical cross-match to be positive. So one of the big points is clinical decision makers need to be educated about the non-immunological factors leading to a positive physical cross-match, just like the paper that Lewis showed, with basically the same results, whether you have a positive or negative physical cross-match with a negative virtual cross-match, no antibody. So if you're transplanting with no detectable antibody, it doesn't matter if your physical cross-match is positive or negative. So positive physical cross-matches with low or no detectable DSA should be interpreted as clinically negative. and the kidney transplant should be proceeded with. So then the question is, are we at the point where we can, is there any benefits for using the physical crossmatch? And I think if you're a program that transplants against known antibody, the physical crossmatch is certainly a great way to stratify the immunological risk. Like Lewis was saying, the CDC crossmatch is, are you dealing with a positive CDC, which nowadays no one is going to really be doing, particularly if you have pair donor exchange, and you just have a positive flow crossmatch. When we first, 15, 18 years ago, when we were doing desensitization, we would use the CDC crossmatch as whether or not we would do plasmapheresis prior to transplant or just give IVIG and Retux. And that's really how we figured out that if you have an MFI in class 1, for example, greater than 8,500, you're at a high risk for having an antibody response. If you're doing cross matches with your AB and DR with low MFI, say you have MFIs in the 2,000 to 3,000 range, and it's giving you a higher flow cross match than you suspect, it could be due to the antigen density on the cells, or is there something else going on? It's going to lead you to further testing of the recipient and of the donor to really try to tease out what's going on. And certainly, if you have C and DP loci with MFIs over 5,000, even to 10 or 12,000, you can sometimes have a completely negative crossmatch, flow crossmatch. And are you going to modulate them, or are you just going to transplant them and follow the antibody levels to see what's going to happen? When you're thinking about, and one of the things that we're going to at our institution is because of the limitations and the difficulties with staffing at our institution, we're trying to go away with doing physical cross matches in the middle of the night. It's certainly saving the techs from having to come in the middle of the night, particularly when we don't have as many people in lab as we used to. And so we're at our institution, we require that the patient has defined antibody testing, and we look at having at least a screening every month and having at least a single antigen or screening test within 30 or 60 days. And when you're calling somebody in, the coordinators make sure that there are no sensitizing events like blood transfusion, for example, for the patients. And we've really started looking at 0% CPRA recipients, zero antigen mismatch recipients with no DSA. And if you're a risk-averse program, don't even look at anybody with any level of antibodies. We are a program that will transplant with known DSA. So for our patients with a higher CPRA, we'll look at higher levels of accepting C or DP, and we'll just plan on doing modulation of the patient. But we know that the cross-match is going to be positive. So in this particular case, we know that the virtual cross-match is going to be positive, the physical cross-match is going to be positive, and we're still going to go ahead with the transplant. So the virtual cross-match clinically is fantastic at donor and recipient selection. And secondly, if you're looking to go to the OR with just the virtual cross-match as a final cross-match, it's very helpful in overcoming the logistics related to OR timing and leading to a decreased cold ischemic time. And lastly, once again, a positive physical cross-match with no DSA is due to non-HLA factors, and it should be considered clinically negative, and the transplant should proceed. And now I think we're going to open up for questions.
Thank you, Dr. Goggins and Dr. Hidalgo, for the amazing talk and for shedding light on the topic from the HLA lab standpoint and offer accepting provider standpoints. Thank you very much. We already have a lot of excellent questions. Some of them were asked early on and then addressed in the second half, which is great. But I'll move to the first question to Dr. Hidalgo. It's asking about the AJT paper that you cited in 2016, comparing a positive physical cross-match group to the negative one. And the question is about that the curve was separating after several years, after 8 years, and whether you can comment on this.
I mean, trying to extrapolate from what happens at 8 years post to a test that occurred at the time of transplant, I think is challenging. That was not addressed specifically in that paper. But my guess is that we tend to see higher rates of false positive cross-match reactivity in patients with autoimmunities. So, and this is just me speculation, I would guess that this is likely pointing towards disease recurrence, perhaps, and that's leading to that. But I would argue it's completely unrelated to the anything that may have been missed at the time of transplant.
Right.
Thank you, Louis. So there are a couple of questions regarding billing. I would just combine them to ask you all in once. Billing for virtual cross-match. So you mentioned currently the Ph.D. directors, are not able to bill their works, involving virtual cross-match. So the question, I guess, is for the colleague at COP who are not ACHI lab directors. They need to understand how much it works. Someone in middle of the night going to do that, do a virtual, is not being properly billed. Is there anything you looking forward to move to a direction to, to make sure the PhD get billed of their hard work?
Yeah, so I mean, this is really an ongoing conversation that we're having. The conversation is at early stages, and it's really unfortunate because I'd argue it's probably about easily 80 to 90% of lab directors out there are PhDs, and all of these cross matches that are being performed in the middle of the night. Even if it's those basic cross matches that I was describing, where the lab staff, not necessarily the lab director, is giving the initial cross match. None of that is really being compensated by the laboratory unless the lab has an MD laboratory director. So I would hope that everybody can understand the unfairness of such practice. But it is something that we're trying to address. And ASHI is certainly pushing for something like this to within to give us the ability for a CPT code that would be applicable for such circumstances. You can look for additional details on this. So I told you about the virtual crossmatch white paper. This is partly addressed also in an additional letter to the editor that should be appearing in that same issue.
Great. There are actually more than one question, Philip, from your surgical colleagues asking about the PRA thresholds for relying on the virtual cross-match, and whether there is a certain threshold in highly sensitized patients where you would worry just using the virtual cross-match when accepting these offers. Any comments on that?
I think one of the prerequisites is that you have to have, for the high CPRA patients, you have to have a very stable antibody profile that and that's why you go through data months. You have, most of our patients have been screened for years, and you have multiple previous Luminex and other testing that you can see. So as long as they have a stable antibody profile and they haven't had any sensitizing events, I go to the OR on the virtual. Yeah, I had the 100% CPRA patient that came back, and there was a minor increase in the MFI from 1,500 or 1,800 to 2,800, which is just part of the test itself. Like Lewis was saying, it's a qualitative analysis, not quantitative, and that didn't affect what we did clinically. And when I reviewed our 33, we did about 33 straight to the OR, 0, completely negative virtual cross matches. And we had 5 positive physical cross matches. 3 were due to autoantibodies and 2 were non-HLA factors. And, doing the physical cross match would not have changed what we do at all. So I think as long as you have a stable antibody profile, I don't think it necessarily matters what your CPRA is.
That's excellent. Just to follow up this, Bill, so if you would, in a situation like this, you move forward and some events happen post and you are concerned that there might be some immunologic process going on. I've seen a practice where people go back and do kind of a retrospective cross-match. Would you rely on that, or you would be just go ahead and order DSAs that would find them more useful after?
We would just look at DSA testing to see where they were and biopsy and seeing if there's any antibody deposition in the patient and go from there. That's how we would handle it. I for a while, and I actually talked to Lewis last year, and that's why we really started to look at going straight to the OR with just the virtual, because we were talking. I said, I already know what the cross match is going to come out as, right? If I have good antibody testing, so why do I need to do the physical cross match? And we started thinking about that, and really we are having a lot of issues with getting good people as techs to work, and we don't want people to leave because they're up all night and working so hard, and it's helping the lab. It's helping the labs very much. In my kidney pancreas, my chief is a kidney pancreas guy. I'm like his new best friend because he doesn't have to wait for the cross match. He would have to bench and wait a couple hours, go to sleep for a little bit, and now he just goes. And I think he likes me even more now.
That's excellent.
Yeah, so I have follow-up questions. A couple of people asked both Louis and Bill is for highly sensitized patients, many times patients have allele specific antibodies. So donor typing currently is not on allele level. There's on the other hand, there could be deceased donor typing mistakes there. So could you comment, on highly sensitized patient? Should we do some flow cross match, or I guess the question to both of you.
I mean, that's a valid point, and it's a discussion that has come up, fairly regularly at HLA meetings. So the practice that we are starting to adopt for highly sensitized patients is to do a stat retype of the donor. And a couple of reasons for that. One, I really don't want to take steps backwards towards cell-based cross matches. And also, more importantly for my staff, I know we can do the real-time PCR typing within 2 hours and not have to spend the 4+ hours that we would need for a flow cross match. So again, you should always be thinking about the staff and how much time they're forced to spend in the middle of the night.
That's great. Just to make this more inclusive to other organs, a couple of questions addressed, from heart transplant, for example, and they were asking whether, would this apply for heart transplant candidates? Is a CPRA of, for example, 10% would be considered high when you kind of decide, when to use a virtual cross match on these recipients who are receiving, for example, heart transplant?
Yeah, I mean, we do the same thing with the heart and lung recipients. You know, even patients that have 80% CPRA. If we clearly have defined the DSA, what the recipient has for antibody, and it's stable, then we won't ship blood in for a cross match. We'll do a retrospective cross match for them like we always do. But then I have to end up explaining to the cardiologist taking care of it, don't worry about it. The cross match is to the non-HLA stuff. So, I mean, as long as you have, like I said, it doesn't matter what organ you're doing, you have to have a stable antibody profile so that you can best predict what's going on. Now, if someone just gets listed and you only have one test, you've only done beads one time, then that's a different patient.
That's great. I think we can probably take another question or two, and we are at the clock. I think we have many questions, but you want to take one more?
I think yours are we were on time. We're at 3 o'clock now. 3:01 now. You want to do a close? Yeah, go ahead.
I think Victoria, maybe you want to take it away?
Yes, thank you. I would like to thank all of our panelists and our attendees for today's session. Please remember to complete the evaluation survey, and the recording of this session will be available later this week. Thank you again